On behalf of the RSNA, thank you for joining us today. My name is Dr. Geoffrey Klein, and I am an RSNA board member and the editor of Radiographics. As you work to address COVID-19 in your practice, it is our hope that this webinar is one of the many ways RSNA is reaching out to the radiology community by providing research, education, and other resources on COVID-19. You can find these resources on the COVID-19 section of RSNA's website, which is updated regularly with new content. A link to the resource page is provided in the chat window. Now, I would like to introduce Dr. Geoffrey Rubin, who is our first speaker and will be moderating today's session. Dr. Rubin is the George B. Geller Distinguished Professor for Cardiovascular Research, Professor of Radiology, and past Chair of Radiology at the Duke University School of Medicine. He is a past president of the Fleischner Society and currently president and board chair of the International Society for Computed Tomography, founding board member of the Radiology Leadership Institute of the American College of Radiology, board member of RadAid International, and host of the acclaimed RLI podcast, Taking the Lead. Dr. Rubin was previously professor of radiology at Stanford University, where he also served as Associate Dean for Clinical Affairs in the School of Medicine and Chief of Cardiovascular Imaging. At Stanford, he pioneered the development of CT angiography and a variety of volumetric visualization and analysis techniques, co-founding one of the world's first clinical 3D imaging laboratories in 1996. I would now like to welcome Dr. Rubin.
Thank you very much, Jeff, for that very kind introduction, and greetings to everybody from around the world. Thank you for spending the next hour of your busy day with us to discuss thoracic imaging and COVID-19. I think that it's fair to say that for all of us, we're seeking ways to provide an environment for compassion and compassionate care for our patients and our coworkers, and that really underlies the initiative that I want to share with you, or that we want to share with you today. With us today, we have Dr. Anne Leung. Dr. Anne Leung is currently professor and associate chair of clinical affairs and radiology, as well as division head of thoracic imaging at Stanford University Medical Center. Her research interests focus on the use of computed tomography to diagnose and evaluate thoracic diseases, including lung cancer. She has authored or co-authored over 95 peer-reviewed articles, 13 book chapters, and 1 book. She serves on several national committees, the National Comprehensive Cancer Network, American College of Radiology, and of the Fleischner Society, and is responsible for the development of clinical practice guidelines for lung cancer screening and management of pulmonary nodules. Dr. Leung is past president of the Society of Thoracic Radiology and a current member of the Fleischner Society's Executive Committee. And a very close friend and longstanding colleague. Anne and I shared offices next to each other for close to 20 years when I was at Stanford. And I can't tell you what a delight it is to be able to be sharing this moment with her to make this communication. Also speaking today is Dr. Chris Ryerson. Dr. Ryerson completed his core clinical training at the University of British Columbia, an interstitial lung disease fellowship and master's degree in clinical research at the University of California, San Francisco, before joining the University of British Columbia faculty in 2011. He is an associate professor at UBC, director of St. Paul Hospital's ILD clinic and research program, and head of the Division of Respiratory Medicine at Providence Healthcare. His research focuses on the management and prognostication of ILD. He is also involved in several national and international clinical practice guidelines on the diagnosis and management of patients with chronic lung disease, and as a member of the Fleischner Society is a critical resource in the development of evidence-based guidelines and statements, and played a very important role in the preparation of the materials that we're going to share with you today. Before we get started, there are a few things to let you know. You may follow the steps on the screen here and in the chat panel. I see a lot of folks have been finding the chat panel already, which is great. But follow the instructions on the screen here to claim 1 CME credit for this webinar if you like. We'll share that information again for you so you don't have to write it down. And we have this brief disclaimer here from the RSNA. So without further ado, let's launch into our program. And in particular, the basis of our conversation relates to this manuscript, which was published, as you can see, on April 7th, just 10 days ago, The Role of Chest Imaging in Patient Management During the COVID-19 Pandemic, a Multinational Consensus Statement from the Fleischner Society. We're all dealing with uncertainty and a lack of formal evidence base at this time in a very rapidly evolving environment. We have come to rely upon evidence when guiding medical practice in the use of imaging. And this project was our attempt to provide that guidance using the best available evidence and global experience available as of late March. This project was a product of teamwork and a team ethos. And I need to underscore that the 29 names that you see listed here are people who committed in a very meaningful fashion during very busy times, taking time away from clinical practice and clinical work in order to provide input for this statement. We're going to follow this agenda during the course of the hour. I want to talk to you a little bit about the statement development process. And then we will hear about factors influencing the use of imaging in COVID-19. We're going to then go into the key questions and clinical scenarios that were developed and are presented in the statement. We are going to have some further polling by the audience to provide our worldwide audience to provide input to us, as did the 29 members of this writing committee. We'll go over our summary recommendations and then have a Q&A session. Let me first just orient folks who might not be familiar to the Fleischner Society. This is a statement from the Fleischner Society, which was founded in 1969 to stimulate the recognition and development of chest radiography as a clinical specialty. It is multidisciplinary and multinational, dedicated to the diagnosis and treatment of diseases of the chest, with 77 active members from 13 countries. The membership is about 50% radiologists, about 34% pulmonary or pulmonologists and intensivists. And then the remaining membership is composed of thoracic surgeons, thoracic pathologists, and a spectrum of non-MD scientists spanning expertise from epidemiology to machine learning to molecular biology and anatomy and physiology. The Fleischner Society has worked to become a unique resource for developing guidelines and scientific statements for the use of thoracic imaging, particularly because of its multinational and multi-specialty composition. And here are just some names of some of the Fleischner publications which you may have become familiar with. So the process of having the Fleischner Society step forward at this moment in time was one that seemed very opportune. This particular writing group is composed of 29 members. They represent adult and pediatric radiology, pulmonary medicine, intensive care, emergency medicine, laboratory medicine, infection control, and pathology. It was very important to us to constitute a group that had a 360-degree view on the problem of the use of imaging in COVID-19 in the thorax, and to have a spectrum of experience and expertise from around the world. I also want to underscore to you that this project, from the time it was initiated on March 20th till the time it was formally accepted for publication in the journals Radiology and Chest, happened over a 12-day window. And I'd like to give you a little insights into that as well. As far as the writing committee, this map shows in color the prevalence of COVID infections in countries around the world at the time that this manuscript was published, and the stars represent the countries that are represented on the writing committee. We had members who had experience in Wuhan, China. We had members on the writing committee who were practicing in northern Italy during the surge there, as well as multiple other countries, and particularly in the US, representing New York City, to provide true insights into those who have had to deal with some of the most dire and urgent circumstances that we have faced. The approach to developing this manuscript, it actually was initiated when I received a phone call from Dave Blumke, the editor of Radiology. In mid-March, he expressed concern that there was not a clear-cut and detailed set of guidelines around how thoracic imaging should be used in the setting of COVID-19, and asked me if I would help to organize a process to establish some clarity through an assessment of clinical scenarios. And immediately, my thought turned to the Fleischner Society. I reached out to the Fleischner executive that very evening. The Fleischner executive, on an emergency basis, approved the process of creating the statement. Dr. Leung, Dr. Ryerson became members of essentially an executive committee to put this together, and we followed on to recruit this group of 29 experts, both from the Fleischner Society as well as beyond. I can't tell you how gratifying it's been to work with this group, and the fact that when it came time to bring people together, emails were answered within hours. Everybody participated who was invited, and when the manuscript was drafted within a 12-hour time interval and submitted within 24 hours, we received 29 drafts and sets of comments that ultimately went to constitute this statement. The statement process began with a comprehensive review of the published literature to date, and then based on that information and then a number of conversations that were carried out amongst the writing committee, the development of clinically driven scenarios. Those scenarios then helped to formulate key questions on the use of imaging that were established from those scenarios. And I want to emphasize, and we're going to hear more about this through the session, that as we refer to imaging within the context of these guidelines, we are referring to the choice of chest radiography or computed tomography. We specifically did not separate recommendations for these two modalities, and as I mentioned, that'll be discussed in more detail coming along in a moment. But I want to emphasize that the target guidance within the context of our statement relates to the notion of clinical actionability. CT and chest X-ray are recommended without specification because of this fundamental focus on clinical actionability as a determinant of the role of imaging. Methodological consideration and consideration of the pros and cons of the use of imaging was done in a very detailed and rigorous fashion. You know, the demands of practicing modern medicine through unprecedented constraints and volumes of patients requiring triage presents a challenge. And our belief is that physicians, nurses, and technologists should not be unnecessarily encumbered from using their expertise and inventiveness to arrive at solutions that facilitate decisions to act in response to novel clinical situations. Examples include the acquisition of radiographs through glass windows in patient rooms, the use of handheld ultrasound for patient management decisions in intensive care units, and even the decision to avoid the use of an imaging test when indicated, but resources do not allow it. And it was really with this 360-degree view broadly that we considered the use of imaging as a clinically actionable intervention. The ratings that we are going to share and discuss were generated through independence amongst the individual raters and anonymously conducted, and agreement was defined as greater than or equal to 70% to establish consensus. This is figure 4 from the manuscript, and I hope that you have all had a chance to go to Radiology's website and access the manuscript. It is available for anybody to access. And here you see a list of 14 key questions and the results of the ratings. And to carry the conversation further and to take us to an understanding of these key questions and a number of considerations that were brought to bear around the creation of the clinical scenarios, I want to hand the podium over to Chris Ryerson. Chris?
Great. Thank you, Jeff, very much for the kind introduction and also for spearheading the entire project. This was a great experience, I think, for all of us. So this slide illustrates the voting that we took on 14 key questions. We had 27 participants out of those 29 who were able to make a weekend conference call where we reviewed 3 different scenarios that we thought were all clinically relevant scenarios in which chest imaging could be performed, or at least the question of chest imaging was raised. We had those 3 different scenarios and 14 different key questions that related to those 3 different scenarios. And we'll go through the first 11 of these questions, which are really embedded within those scenarios, as well as 3 additional questions that were outside of those 3 scenarios. We had each member vote anonymously and independently on their rating for or against imaging for each of these scenarios. And raters were asked to either strongly agree or strongly disagree with the use of imaging for each of these options. And then weak in favor and weak against and neutral recommendations as well. This is the breakdown of the votes, and we will move forward and discuss each of these different scenarios. As background for these scenarios, there were 4 key components, or 5 key components that we want to explain that really outline the key features of each of these scenarios. So the first thing that we discussed being related to each scenario was the severity of respiratory disease. And we dichotomized this as patients who present with either mild respiratory disease or moderate to severe respiratory disease. And we define this somewhat arbitrarily and somewhat vaguely as the presence or absence of pulmonary dysfunction or damage. And specifically, we defined pulmonary dysfunction or damage as the absence of hypoxemia, having none or mild dyspnea. There are additional examples. Respiratory rate could be a factor. But essentially, we wanted to characterize patients as though they have mild disease that potentially could be managed as an outpatient versus more moderate to severe disease that would likely prompt admission to hospital. The next feature that we used to guide our scenario development was the pretest probability of a COVID-19 infection. And this, we took some language from the CDC, which has categorized the pretest probability as being low, medium, or high based on the type of transmission that is happening in the community. So low pretest probability is defined generally by sporadic transmission. So this is a situation where the occasional patient is coming into hospital and being diagnosed with a COVID-19 infection. Medium pretest probability is characterized by clusters of infection in the community. So these might be examples of long-term care homes with a few different cases, but without widespread infections being identified within the community. And then high pretest probability is characterized by widespread community transmission, as we've recently seen in New York, as well as in Wuhan, Spain, and Italy, and other regions. The pretest probability is, of course, further modified by the individual's exposure risk. So if you are a long-term care worker who has patients in your facility that have tested positive, that obviously is going to put you into a higher pretest probability of having a COVID-19 infection. If you are working in a hospital or live with another family member who has been diagnosed, those obviously would be additional features that would increase the likelihood of a pretest probability of COVID-19 infection. If we move on to the next slide, the next feature that guided our scenario development was risk factors for disease progression. So this is different than risk factors for the disease. This is specifically risk factors for the progression of disease. And this is a growing list that is continually being added to and largely comes down to a clinical gestalt on how worried you need to be about this patient and the risk of their disease progressing. So some common risk factors for this would be older age, the presence of comorbidities such as cardiovascular disease, diabetes, chronic lung disease, hypertension, ACE inhibitor usage, immune compromisation, and multiple other factors. And we're starting to learn more and more about this with some recent publications. The absence of risk factors is really just defined by the absence of these features. And it's important to consider that these things don't exist in isolation. The presence of multiple risk factors, of course, would increase the risk of having disease progression. Disease progression itself, we defined as progression from mild to having moderate to severe disease. And again, defining moderate to severe disease as having the presence of pulmonary dysfunction or damage. And again, characterizing that by presence of hypoxemia or moderate to severe dyspnea. In patients who already have moderate to severe disease, disease progression would be identified by having worsening objective measures of hypoxemia. This is, of course, a continuum. We've dichotomized things for the purposes of illustration, but obviously these things are a continuum, and the definition of disease progression is going to depend upon multiple different factors that all have to be integrated together. The last thing that we considered in our scenarios was the presence of significant resource constraints. This is something that we're not really used to usually in our practice of medicine, at least for most of us. But in the current context in some regions of the world, there have been major constraints on the availability of personnel, of personal protective equipment or PPE, of testing ability for COVID-19, including swabs, reagents, or personnel, the availability of hospital beds, critical care beds, and ventilators. And with these constraints, our approach to management of patients changes significantly to doing whatever we're able to do. So this is more battlefield medicine than what we are usually used to doing in our usual daily practice. So we move on to the next slide. We developed these scenarios, and then we developed nodes where we have a decision to perform imaging or to not perform imaging. And we asked raters to vote on whether we should do imaging in each of these scenarios based on the clinical actionability of the results of that imaging test. And specifically, the utility of imaging in this context could be to triage patients, to decide on whether they should be admitted to hospital or sent home, whether they should come to an intensive care unit or to a regular ward bed. Also, patients may be managed differently. There are scenarios in which identification of multilobar pneumonia may prompt antibiotic use, as an example, or identification of other complications or other diseases that are occurring concurrently. Prognostication is another clinically actionable result that could be yielded by imaging. These, of course, have to be balanced against the costs and harms of imaging, and just a selected list of examples here include radiation exposure, the risk of infection transmission, both to healthcare workers who are dealing with patients who have an infection, as well as to patients who are undergoing evaluation for a potential infection that don't actually have this. In addition, there's consumption of personal protective equipment through radiology staff, through nurses who have to transport patients, and patients themselves who are often being asked to wear masks when they're going for these tests. There are other resource impacts, and this applies to critical resource constraints again, where we have room downtime when patients come into the room, and the room then needs to be cleaned after patients with an infection go through the CT scanner. And this leads to less ability to scan other patients. So these are some of the harms. This is not an exhaustive list, but these are the balances between the benefits and harms of doing imaging. And at each step, we considered both these benefits and the harms, and we'll go through that with each of the scenarios. So if we move on to the next slide, this is the first scenario, and Anne will walk us through this in more detail.
Thank you very much, Chris, and big thanks to Jeff for his kind introduction. It's been a real pleasure for me to participate in this process and to be present participating in this webinar today. So I'd like to begin by providing some context to the scenarios. Each of the three scenarios is defined by the severity of the patient's presenting clinical features, the pretest probability of COVID-19, and the presence of medical resource constraints, if any. The diagnostic algorithm in each scenario will always begin with the performance of a molecular test for COVID-19, either real-time reverse transcriptase polymerase chain reaction assay or a point-of-care rapid COVID test, which are both considered as first-line tests for diagnosis of active infection. As I go through the scenarios, I will remain agnostic as to the type of indicated imaging study chest X-ray, or CT, but rest assured, at the end of each scenario, we will be discussing modality selection. And in fact, you will be polled for your opinion as to which you would choose at some of these decision points. So having said that, let's begin with this first scenario, which addresses patients who present for medical care with mild features suggestive of COVID-19, such as cough, fever, and sore throat. These individuals would likely be evaluated in an outpatient clinic setting or via telehealth. Scenario 1 encompasses any pretest probability of infection, and there are no resource constraints in the medical environment. So scenario 1 begins with performance of a COVID-19 test. If a COVID test is unavailable, either due to lack of tests or delays in the availability of test results, patients with moderate to high pretest probability should be initially managed as if COVID tests were positive. Conversely, if pretest probability is low, patients should be managed as if the test were negative. In patients with a positive test or moderate pretest probability of infection, we next consider if they have risk factors for disease progression. If such risk factors exist at node 1, we advise imaging to provide a baseline, to look for superimposed processes, and to assess extent of disease, which may inform decisions as to the intensity of monitoring, including potential need for hospitalization. If risk factors are absent at node 2, we advise no imaging be performed in patients with mild features. Patients are instructed to self-monitor for worsening respiratory status, and based upon the known disease characteristics of COVID-19, we anticipate that the vast majority of these individuals will recover without need for further medical care. However, if patients in either of these two groups with or without risk factors should experience worsening respiratory symptoms, at node 4, we recommend imaging with goal to differentiate between progression of COVID-19 from a new and potentially treatable process. Now, coming to the other side of the chart, in patients with mild features, if the COVID test is negative or if there is a low pretest probability of infection, we do not advise imaging. In this setting, the patient presumably has a non-COVID-19 viral infection, such as adenovirus or metapneumovirus, both of which are usually self-limiting. At node 3, the panel felt imaging would be of low value and that it would be safe for patients to self-monitor. If in fact patient does experience worsening of their respiratory status, at node 5, imaging is again advised to determine the cause of the clinical deterioration. So Chris, at this point, let me please hand this back over to you.
Sure. So we have our first polling question now. So that should be available on your screen. And the first question is imaging indicated in a patient with mild features, a positive COVID-19 test, and risk factors for disease progression? So this corresponds to node number 1 on the screen before you. And again, we want to ask people to think about the clinical actionability of results that could be gained from imaging in this situation compared to the potential downsides, as we've discussed before. This is the same question that we voted on as a group. We don't want to bias anybody based on our decisions, and we'd like to have the audience vote on whether they think imaging is indicated or not indicated for this scenario. All right, so let's move on to our next polling question. And this is in relation to node number 2. So this is the question, is imaging indicated in a patient with mild features, a positive COVID-19 test, and no risk factors for disease progression? And again, you know how we have voted as our panel, but we would like to get the opinion of the audience. And again, considering the clinical actionability of results that would be anticipated from such a test compared to the potential downsides of performing that test. And again, our intent with asking these questions of the audience is to get a sense as to the broader impression of what to do in these scenarios from a large group of people practicing around the world. We're not showing you the results of these questions right now because we don't want to bias people with our next few questions, but we will be endeavoring to share these in some platform in the near future. And with that, I'll hand it back over to Anne to take us through the next scenario.
This second scenario pertains to patients who present with moderate to severe features: fever, malaise, shortness of breath, any pretest probability of infection, and there are no resource constraints in the medical environment. With more severe respiratory symptoms, these patients need to undergo evaluation to determine disposition, whether they are able to safely go home or will require admission. This scenario again begins with the performance of a COVID-19 molecular test. If the test is positive at node 6, we advise that imaging be performed to establish a baseline, look for possible superimposed and treatable processes, and to assess for extent of disease that may help in determining patient disposition to home or hospital. If the patient's respiratory status should clinically deteriorate at node 8, we advise that imaging be performed to distinguish progression of infection versus development of a new superimposed process. Coming to the other side of the chart, in patients with negative or unavailable test result, either because of unavailability of testing or due to delays in test results, at node 7, we advise that use of imaging largely to provide an alternative diagnosis. If an alternative diagnosis is not identified, or if there are imaging features suggestive of COVID-19, further management would be dependent on patients' pretest probability of disease and availability of COVID tests. So for example, in communities with sustained transmission where the pretest probability of disease is high, the possibility of a false negative test result may lead to retesting if that option is available. So Jeff, may I please hand this off to you for the next polling?
Yes, now is the opportunity for everybody to provide us with your views around key question 6. And the specific key question here is: imaging indicated for a hospitalized patient with moderate to severe features and a positive COVID-19 test within an environment where there are no resource constraints. Please let us know what you think. Is imaging indicated for a hospitalized patient with moderate to severe features and a positive COVID-19 test? Okay, all right. Well, thank you for giving us your impression. And Anne, I'm going to move this on to the next scenario.
Thank you. So our last and third scenario addresses patients who present with moderate to severe features of COVID infection in a community that has experienced sustained infection transmission that has now led to both a high pretest probability of disease as well as significant critical medical resource constraints: lack of hospital beds, ventilators, medical personnel, PPE, and COVID tests. This scenario simulates the challenging conditions experienced in areas such as Wuhan, Northern Italy, and New York City, where severe outbreaks effectively overwhelmed medical systems. Because of large numbers of sick patients who simultaneously present for care, there is a need for rapid triage and medical decision-making to optimize allocation of the limited resources and to minimize infection transmission to medical personnel who may lack PPE. This scenario again begins with performance of a COVID-19 test. Currently in the US, there continue to be areas where there is limited testing capacity. And even for those communities who do have testing, routine RT-PCR, which is the standard test, the turnaround is still 12 to 48 hours. Rapid point of care COVID tests are now available, but in limited supply. At Stanford, we use these in our ED, and the turnaround time is around 1.5 hours to 2 hours from collection to test result. So in this scenario requiring urgent patient triage, we recommend performing a rapid COVID test if available. If the test is positive, at node 9, we advise imaging, preferably a chest X-ray, to establish a baseline, to look for superimposed treatable processes such as bacterial pneumonia, and to assess severity of lung disease, information which can be used as additional data to aid in medical decision-making and rapidly determine patient disposition. If this patient experiences worsening of respiratory status at note 11, the panel again advises that imaging be performed to determine if there is a superimposed treatable complication versus progression of the infection. Coming to the other side of the chart, if a rapid COVID test is not available or negative at note 10, we advise that imaging be performed to look for alternative diagnosis. If an alternative diagnosis is not identified or there are imaging features suggestive of COVID, a presumptive diagnosis of COVID can be made in this high pretest probability environment, which in turn facilitates medical decision-making as to the appropriate patient disposition, the required infection control measures, and potentially management options such as the type of hospital bed. So Chris, let me please hand this off to you again for polling.
Actually, I'm going to jump in and help with this poll. We're going to be asking you all about scenario 9, key question 9. In a resource-constrained environment, is imaging indicated for a patient who presents with moderate to severe features and a positive COVID-19 test? Realizing that imaging could represent radiography, it could represent CT. If either one of those you feel are useful in this scenario, resource-constrained environment, patient with moderate to severe features and a positive COVID-19 test, please indicate that. Or if you think that it shouldn't be done, then please indicate that through the poll. All right, well, thank you for providing us with that input, and we hope to share those results down the line once we have a chance to see them ourselves. But part of the process of the polling that we just conducted here is identical to the process that was conducted with the 29 expert panelists. They did not have exposure to others' votes, and they voted in an anonymous and independent fashion as a means of preserving each person's opinion without being swayed by groupthink or any particularly dominant voices. But I do want to emphasize that the voting process occurred simultaneously during a 2-hour session in which all panelists were present and were able to interact through an online platform. I'm going to then summarize the recommendations that we provided in our document. And the main recommendations essentially are fivefold. And that is that imaging is not routinely indicated as a screening test for COVID-19 in asymptomatic individuals. Imaging is also not indicated for patients with mild features of COVID-19 unless they're at risk for disease progression. And of course, the definitions for disease progression, Dr. Ryerson went over and are specifically called out in a table in the manuscript. We do find that imaging is indicated for patients with moderate to severe features of COVID-19, regardless of their COVID-19 test results, and that imaging is indicated with COVID-19 and evidence of worsening respiratory status. Finally, in a resource-constrained environment where access to CT is limited, chest X-ray may be preferred for patients with COVID-19 unless features of respiratory worsening actually warrant the specific use of CT. There were 3 additional questions that were discussed within the context of the panel evaluation that were not part of the scenarios. The first recommendation was that daily chest radiographs are not indicated in stable intubated patients with COVID-19, that CT is indicated in patients with functional impairment and or hypoxemia after recovery from COVID-19, and that COVID-19 testing is indicated in patients incidentally found to have findings suggestive of COVID-19 on a CT scan. We will, at this point, then transition into our question and answer process and to welcome back, hopefully, to everybody's screens, Dr. Leung and Dr. Ryerson. Let me first say that it is gratifying to see all the questions coming up that have been presented, and we're going to try to get through just as many of the questions as we can. But I'd like to ask the first question to Dr. Leung, and that is that we have seen statements from the RSNA. There were pre-existing statements from the ACR. Can you describe why the Fleischner statement is different, why it was needed, and why the recommendations might be perceived as being different from, for example, the ACR recommendations?
Thank you, Jeff. I would say that what makes, I think, the Fleischner statement hopefully very helpful is that it is written at a later point in time. And now we have more information that we can integrate into our recommendations. Another feature that I think distinguishes it from guidelines that have been issued by the ACR RSNA is that Fleischner is a multidisciplinary society. And for this statement, in fact, we went even beyond the confines of Fleischner with its multidisciplinary nature to seek additional experts who could bring their domain expertise to the issues at hand. Coming back to your specific question regarding differences or similarities between Fleischner's statement versus the ACR statement, I would say that, in fact, I see these two statements as being very aligned. And when I read the ACR statement or guidelines, they recommend, first and foremost, that CT not be used to screen or serve as the first-line test for diagnosis of COVID-19. And our panel obviously agrees with this, because in each scenario, we start with a COVID-19 test, if in fact that is available. The ACR recommends that imaging be used cautiously so that only information generated will guide patient care decisions. And clearly this is necessary caution, because we do not want to image patients for which there is no value added. I think that's very critical, particularly when we're talking about a contagious disease, and we need and must protect healthcare workers. So I think that, when I reflect upon our statement and ACR's, I believe they're very aligned. And then when I look at our statement and what was put out by the RSNA, an extremely well-crafted, useful document that speaks to guidance in reporting of CT findings, as opposed to ours, which obviously is on the use of imaging.
Thank you. Excellent. Well articulated. Chris, why don't the recommendations strive to distinguish between chest radiography and CT?
Thanks. That's a great question. And that's something that we struggled with quite a bit at the beginning of our discussions as well. And as we worked through our scenarios, we realized that we were very hung up on specific considerations of whether we should be doing a chest X-ray or a CT scan at each of these nodes. And really the preference for one versus the other, there were so many specific considerations that it was impossible to account for all those possibilities without making scenarios that were prohibitively complex. So we therefore decided to keep it simple to some extent and make recommendations for imaging that would then be dependent upon the patient-specific details. If we go to scenario one, just to illustrate that quickly, so question one, or node number one, we have a patient with mild features and risk factors for disease progression. This is a patient who we're quite likely going to be sending home from hospital. And when we're looking at that scenario, in most circumstances, or maybe almost all circumstances, we're going to be thinking about doing a chest X-ray in that patient to identify major abnormalities that would change our management. Again, that would be clinically actionable. So in that situation, we likely would be talking about doing a chest X-ray. If we move on to scenario four, or sorry, node four of scenario one. So node four, that same patient who now comes back to hospital, who has had some progression of their disease, There are going to be a whole bunch of additional features to that scenario that will dictate whether we would prefer doing a chest x-ray or a CT scan. And that could relate to what imaging modality they already had and what abnormalities were present on that test. Could relate to whether they have calf swelling and concern about a pulmonary embolism. Could be dependent upon whether they have asymmetric breath sounds and the risk of a pneumothorax. So there'll be a whole bunch of different things that will dictate whether we would prefer to do a chest x-ray or a CT scan. And so that's the main reason why we made these decisions agnostic to the type of imaging. If we move on to scenario 3, there's another example here. So in question 10, so this is in a resource-constrained environment, but a high pretest probability of infection. The choice of imaging modality will depend on a lot of the risks of disease transmission and the acuity or the timing of the presentation of those patients. If you are using imaging as a way of trying to triage patients and identify whether a patient has a high likelihood of COVID infection or not, the timing of that presentation is going to impact your decision of which modality to choose. As an example, in Wuhan, China, patients were encouraged to present very early in the course of their disease. And we know that chest x-ray is going to be very poorly sensitive early in the disease for COVID-19 infection. CT scan, on the other hand, has variable but quite a bit higher sensitivity at that stage. And so if you're trying to use imaging in that resource-constrained environment where you have limited access to swab testing in a timely manner, and you need to use some other modality to triage patients, CT scan would be much more effective earlier in the course of disease than chest x-ray, which often will be unremarkable or non-contributory early in the course of the disease. So that just illustrates a few of the decisions that we struggled with about which test modality to perform at each node and why we left it really in the hands of the physicians who are on the ground and dealing with those specific patients. Anne and Jeff, any further comments on that? It's a difficult question and one that we struggled with quite a bit.
Chris, I think you really well articulated the difficult situation. And I think that at the end of the day, the physicians who are taking care of the individuals need to make that modality selection based upon the clinical context, the type of study that will answer the question in the most effective way while minimizing potential infection transmission and using the resources that are available to them at the time.
Yes, I want to emphasize the variation that we encountered amongst our experts in terms of practice environments between China and Japan and France and the United Kingdom and Italy. There are constraints and specific circumstances that exist all over the world. And sometimes for us sitting in our local practice environments, it can be hard to anticipate the restrictions and constraints that may exist in other practice environments, particularly in the setting of scenario 3. And so because of the breadth of input that we received, we really felt that it was important and valuable to leave the decision as the appropriate modality to the expertise of the local team that is much better oriented to be sensitive to the kind of conditions that they're facing and to make the right decision. You know, while we're on the topic of imaging modalities, there's been a number of people asking about chest ultrasound. And chest ultrasound is a technique that has been used, for some time in the intensive care unit. Some people are talking about it in the emergency department. In our statement, we opted not to include a chest ultrasound, partly because of a paucity of data to support its appropriate use, but also, frankly, to a relative lack of direct experience amongst the panelists. But I wonder, Chris or Anne, if you might offer a comment on your perspective about the role of chest ultrasound.
I think that having looked in the literature, this is best documented for use in pediatric patients. in whom it might be more amenable. I think that because of the paucity of direct evidence within the COVID population, it's hard to give any type of suggestion. And I think as radiologists, we are all very aware that ultrasound is a modality that is very user specific. So to the extent that the operator is going to do a very comprehensive job in evaluating for abnormalities that do tend to predominate in the subpleural spaces, I think that one might yield a reasonable sensitivity, but there is that aspect. Another aspect that was brought to our attention is that this requires a fair amount of proximity and contact with these presumably suspected or infected individuals. And so that caution needs to be applied when we do these types of procedures, not knowing what their diagnostic yield is.
Thank you. And maybe you might comment on what is the recommended personal protective equipment for technologists performing chest radiographs or CT scans?
That's a very, very important question, and one that we thought important enough to address in our statement. I think the difficulty is that PPE recommendations vary across practices, they vary across countries, likely related to their availability. In the US, the CDC, the Centers of Disease Control, recommend a surgical mask, an N95 if that's available, face shield and goggles, gloves, and a gown. In other countries, it may be more. In other countries, it may be less.
And while we're on the topic of protection and infection control, what infection control precautions need to be followed when performing a chest radiograph or a CT scan?
So I'll take that one as well. I think it's important for all of us to be aware that the primary modes of spread of SARS-CoV-2, the virus that causes COVID-19, in the radiology suites are droplet followed by contamination of surfaces. So when I think about this, there are effectively two main strategies to minimize infection transmission when performing either chest x-rays or CTs. The first is really to control the source. This means having the patient masked during the entire encounter so that droplets don't have the opportunity to spread. It's to keep the infected individual isolated in a room, so again, limiting the opportunity for contamination. This also means that for us, we provide radiographs within the patient's rooms. These are done portably. The second consideration is really to protect medical personnel and other patients. So all medical personnel who come into contact with the suspected or infected patient needs to wear appropriate PPE and be trained to put this on and off. So recently we found that we thought we had done adequate training and we needed to do additional training. And this is extraordinarily important that if they have it, that they actually use it appropriately. Patients should be imaged using dedicated equipment, if possible, that is then cleaned and disinfected after each patient encounter. And if the patient is masked, our infection control team at Stanford believe there is no concern for aerolization of virus. So we don't ventilate the room. We don't leave it empty for a period of time to sit unused. They feel this is not necessary and the amount of time required to clean the equipment is sufficient to for it to be safe to reuse.
Terrific. Another question that has come up frequently is how frequently should chest radiographs be acquired in COVID-19 patients? And I'll take this one and say that according to our scenarios and our guidelines, really the implication is that imaging is indicated when there is a significant change in clinical status. And so we do not advocate the routine acquisition of imaging studies in people even who have severe features of COVID and are hospitalized unless there is a specific decision point to be undertaken as a result of the event of clinical worsening. And so chest radiography or any imaging should be dictated by changes in the patient's status. Another question that has come up a fair bit, and I might turn to you, Chris, to ask about this, is here in scenario 3, and if we could bring up the scenario 3 slide for a moment. The question is are there examples that can be provided that might articulate the role of chest CT in triaging patients within this environment of a resource-constrained, high pretest probability, moderate to severe features?
Yeah, that's a great question. So we're talking mostly about scenario 10, I believe. So in scenario 10, we're in a situation where we have a negative COVID-19 test, a rapid negative test, or the inability to rapidly test patients. And specifically, we're thinking more about when we have an inability to rapidly test patients, can we use imaging to medically triage those patients? And in that situation, I think CT scan does have a role if you have to make decisions in a rapid manner without having the ability to get a swab on those patients before making those decisions. And in that situation, I think CT scan does have a role. We obviously would prefer to get a swab and make a decision based on that swab. But if you have a high pretest probability, you are unable to get a swab, and the CT scan shows features consistent with COVID-19 infection and does not suggest an alternative diagnosis, that should be considered a presumptive diagnosis of COVID-19 infection, and the patient should be isolated and managed appropriately. Obviously, we have to have a high index of suspicion in that situation for other complications, other diagnoses, but that should be a used modality in that situation specifically.
Thank you, Chris. You know, at this point, we're coming very close to the top of the hour, and before I hand the podium back to Dr. Klein to close us out, I just want to express my appreciation to Drs. Leung and Ryerson for helping to unpack the complexities of this Fleischner statement, the management of patients in the setting of the COVID-19 pandemic. I also want to thank the RSNA for their support in providing this platform for us to reach all of you worldwide. And especially I want to thank all of you, our audience, who have taken the time to spend with us and to gain as much information and new knowledge that you can in the interest of taking care of your patients, taking care of your coworkers, and creating the most effective healthcare environment with imaging that you can. It's been a true pleasure. I thank you very much. And at this point, I hand it to Dr. Klein.
Thanks, Jeff. I too would like to thank today's faculty, Drs. Rubin, Leung, and Ryerson, for sharing their expertise, and thanks to our audience for attending today's webinar. Please look at the chat panel for details on how to earn CME for this webinar. Also, I would encourage our viewers to continue the conversation on RSNA's new COVID-19 community site, where RSNA members and leaders will provide commentary on issues related to COVID-19 and answer questions. Please see the chat panel for the link to this site. Thank you very much.